Today, we're learning about how newborn screening was formed and how funding for newborn screening for sickle cell diseases was instrumental in building newborn screening genetic services and state public health programs. First, I'm presenting a short overview of newborn screening and how those programs have expanded over the last 20 years. And next, I want to focus on newborn screening for sickle cell diseases because I think it allows us to see how newborn screening programs were built. For example, the advocacy for newborn screening for sickle cell disease illustrates the community role in newborn screening in general, and this community role has been instrumental in driving both newborn screening's beginnings and its expansion. First, what is newborn screening? Each year in newborn screening programs, more than 4 million US infants are screened to detect multiple, mostly inherited conditions that threaten an infant's life and long-term health. Newborn screening occurs all over the world, and currently about 35% of babies worldwide receive newborn screening for at least one condition. Newborn screening is considered a vital public health system, much like our immunization programs, that prevents or reduces catastrophic consequences to the babies and families affected by the screen disorders. If not treated, some disorders cause premature death, like sickle cell disease, galactosemia, maple syrup urine disease. Others may cause mental disabilities like phenylketonuria or congenital hypothyroidism, and still others cause physical disabilities like short stature or sexual ambiguity. Structurally, newborn screening is a very complex system that includes the public health department, healthcare services, families, insurance companies, manufacturers, parents, and the system may be divided into 5 component parts, consisting of screening and diagnostic testing, evaluation, and follow-up and treatment, with education as a part of all of these components. And all the parts of that system need to be coordinated to function properly. For instance, you cannot screen an infant without being able to deliver a treatment and the ability to pay for that treatment. On the next slide, we see how all the parts of that system tie together. Coordination occurs between state public health departments and clinics and schools, and we often see regional and national coordination to share resources. For instance, CDC has a lab for quality assurance that serves all state public health programs. Screening includes hospital-based screening, as with hearing screening and congenital heart disease screening, or sample collection and sample submission with laboratory-based screening. This is followed by giving the screening results to the family, and if screen positive, the diagnosis is confirmed, which entails subspecialist assessment, usually with additional testing, and sometimes that's with DNA. The process is both clinician and protocol driven, and if needed, genetic counseling is offered. If the infant is diagnosed with the disease, treatments are prescribed, and referrals are made for further evaluation or treatments if needed. What's important, though, is this system operates universally regardless of place of birth, race, income. And education is key to the system, ranging from education of families to healthcare professionals. How did newborn screening begin? As I indicated earlier, newborn screening largely came through collaborative efforts by parents and the physicians who treated their children. This collaborative model is a model that continues today when lay advocacy groups have advocated for conditions to be added to screening panels. Newborn screening began first in 1963 in Massachusetts, Delaware, Vermont, and Oregon, when these states began screening for phenylketonuria. Over the next decades, congenital hypothyroidism and a handful of other diseases were added to state screening panels on a state-by-state basis. But by the 1990s, changes in screening panels would be dramatic. Originally, conditions were screened one at a time with screening technology used to screen one condition. But in the late 1990s, we saw an expansion of screening technologies and the ability to use multiplex technologies. States can now screen for many conditions at one time. We also saw the introduction of point-of-care screening. For example, newborn screening programs for congenital hearing loss were established in the 1990s. An expansion of screening panels has continued over the past 10 years, often with little uniformity between states. As the programs grew and developed, there was an extraordinary variation from state to state, and there was no national unified or systematic evaluation of either the rationale for screening or the outcomes of such screening that was embraced by the states. This was the situation in 2000, and it was a time when what you were screened for depended on which state you were born in, because there was no agreement on what conditions should be on the screening panel. But the early 2000s brought two major events that set the stage for bringing uniformity across the country. The first was the establishment by the Child Health Act of the Secretary's Advisory Committee on Heritable Disorders and Newborns in Children. And the second was a report from the American College in Medical Genetics and Genomics to the federal government that proposed a uniform panel for newborn screening. Shortly after the recommendation from ACMG was made, the committee recommended adoption of the uniform panel, now known as the Recommended Uniform Panel, or RUSP. In 2006, the Secretary of Health and Human Services adopted the RUSP. And on the next three slides, you can see the effect of these two events. Here we are in 2000, where most states screened for less than 8 conditions. And pretty much the majority of states only screen for 5 or less conditions. So this was right when the committee was for the Child Health Act was enacted, before the committee was formed, and before the ACMG report came out. Here, this was on the eve of the publication of the ACMG report. Now, most states are screening for more than 8 conditions. And then now we have most states screening for the core conditions, at least 30 of the core conditions that are on the recommended uniform screening panel. Now let's take a look at the history of sickle cell screening for sickle cell disease and how a community-based program was built. The transformation of sickle cell disease from obscurity in Africa to visibility in America over the past 100 years is intertwined with politics and race relations unique to America. As in any public health crisis, the community role in sickle cell disease in the United States progressed through stages of denial, stigmatization, acknowledgement, and then advocacy. Parallel to the development of conventional scientific understanding of the disease and the evolution of disease control strategies, sickle cell disease also developed socio-politically. The community began advocating for screening. Screening for sickle cell disease began in the late 1960s, and it wasn't newborn screening per se, but it was a targeted screening program. It focused on screening just people deemed to be African American. Several factors led to the recognition of the importance of sickle cell disease and its contribution to infant mortality. First, a report was published in 1934 that indicated Memphis, Tennessee led the nation with an 11% infant mortality rate. Sickle cell disease contributed to this high infant mortality rate. By the 1950s and 60s, noteworthy racial disparities in overall mortality rates among children, and the estimates of high mortality in the first 2 years of life among children with sickle cell disease could no longer be ignored. But it was almost 3 decades later, in 1971, the president at that time, Nixon, included sickle cell disease in his health message to Congress, paving the way in 1972 for the National Sickle Cell Anemia Control Act. And it brought a unique focus to sickle cell disease and money for research. And of course, at this time, there were some early state newborn screening programs that had begun. But by 1983, only 3 states screened universally, not targeted, but universally for sickle cell disease. And this was Texas, New York, and Colorado. So universal screening programs were few until 1986, when the landmark prophylactic penicillin study was published. This study demonstrated the life-saving benefit of penicillin prophylaxis against pneumococcal infection in infants and young children with sickle cell disease, and provided the impetus and justification for universal newborn screening in the US. Following publication of the study, the National Institutes of Health convened a consensus conference that resulted in unanimous support for the universal screening of sickle cell disease and state newborn screening programs. And in fact, it was such a dramatic study that they stopped the study midstream and came forward with these recommendations. They also recommended regionally centered laboratory services to improve efficiency and minimize potential errors. By 1999, so it's still much a delay, so 13 years after these recommendations, all but 9 states in the US had implemented universal newborn screening for sickle cell disease. And it wasn't until 2006 that we finally achieved universal screening. Think about it, 20 years from a scientific recommendation to completion. The final push for that last state, which was New Hampshire, came from the ACMG report and the recommendations from the Secretary's Advisory Committee. So for those who are advocating for a particular disorder, I think it bears looking at some of the history of how long it can take for recognition for a condition to be placed on the recommended uniform screening panel. Some of the reluctance to embrace universal sickle cell disease are particular to that disorder, and they illustrate a lack of social equity in this country, but also illustrate misunderstanding of population genetics and migration patterns, and lack of knowledge about the impact of slavery and the relationships established by slavery. Congress increased funds for sickle cell disease, and NIH transferred funds from their National Sickle Cell Disease Program and gave those funds to the service arm of the federal government Health Resources and Services Administration, or HRSA. These funds became the basis for establishing genetic services in the states all over the country. With these funds, HRSA funded over 250 general screening programs, 41 sickle cell centers and clinics, education and training programs in genetics and hematology, and state genetic and newborn screening follow-up programs. So the states use these funds for all of their newborn screening programs. So in summary, the socio-political development that propelled investments in research into the disease origins for sickle cell disease, its treatment and models of care resulted in considerable improvements in the life expectancy of people with sickle cell disease over the past 9 decades. The whole process from research to recommendations to funding took decades to achieve universal screening. However, in spite of universal access to newborn screening, healthcare disparities remained and increased mortality remained. The access to healthcare provided by the Affordable Care Act under President Obama became the great equalizer. affording, remember, going back to what a newborn screening system is all about. It's not just screening, it's also providing and affording that treatment. One of the newest programs is the Sickle Cell Disease Newborn Screening Follow-Up Program. This program was established to improve the care and reduce the rates of loss to follow-up of individuals identified with sickle cell diseases and sickle cell trait by supporting efforts of community-based organizations on sickle cell disease education and coordination. Now, sickle cell disease occurs worldwide. This slide shows where there are full-grown sickle cell disease screening programs, and then scattered throughout are in the hashtag areas are where pilot programs are. We have affordable treatments now available that can prevent complications and lengthen the lives of those who have this condition beyond just penicillin prophylaxis. So what do we see in the future? Well, listed here, I've outlined some scientific changes coming or that are needed now in the areas of technology, policy development, and research. Again, using sickle cell disease to frame the future for newborn screening serves to illustrate future needs. And some of these needs are current and immediate. Although we do see research needs and many advances in technology, both for screening, diagnosis, and treatment on the horizon, such as microarrays for disease ascertainment, more comprehensive disease screening, and the use of high throughput genomic sequencing, we're not ready without a robust system of information management. Right now, there remain ongoing challenges with regards to timely follow-up and implementation of comprehensive care for sickle cell disease and all other screen conditions. Wide variation in reporting of screen results by states has led to delays in early intervention. Other states report gaps in compliance with early medical intervention, parental education, and the provision of comprehensive health services. In short, what we need are well-developed health information exchange systems. And this also entails using common data elements and case definitions, as well as the ability to have intersecting exchange of information between newborn screening programs and clinical providers. Under the arena of policy development, only a few newborn screening programs have established activities focused on policy development and system change. For example, despite the recently published evidence-based clinical standards for care for sickle cell disease, and this is true for many other diseases, the available preventive and therapeutic interventions are not reaching the affected individuals. The HRSA sickle cell disease follow-up program is established to monitor the effect of community-based interventions towards increasing compliance. But without the ability to pay for treatment, the newborn screening system remains fractured. I want to thank you for the time.